I'm delighted to say now that we are joined by Dr. Alison Pittard. Alison's consultant in intensive care medicine and anaesthesia, and she is the Dean of the Faculty of Intensive Care Medicine. Alison, over to you.
Thanks, Alistair. I'll just share my screen. So it was very interesting what Jean just said. I think it's about turning what we do on the head, and rather than training people to be able to do everything, is actually looking at what skills are required, then look at the people that have those skills, and then perhaps adopting a team approach. And that wasn't what I was going to say this evening, but that's just struck a chord with something that that we've been thinking of in the faculty. As COVID-19 leads to critical illness for an estimated 5% of infected patients, the experience of critical care staff and resources of critical care become pivotal to the management of the pandemic. To date, there have been around 11,000 admissions to critical care in the UK, and most critical care units have been running at twice normal capacity. And the only way this has been possible is due to the cessation of the majority of planned activity, liberating space and staff to support this massive expansion. And I'd just like to take this opportunity to thank everybody out there listening tonight, and everybody else that you know that stepped up to the mark to help us, because without working together as a team, mucking in together, we would not have got where we are today. And it's just been an absolute eye-opener the way everyone has worked together. Many critical care staff, though, and other staff are still working significant additional hours or periods on call to manage the current numbers of patients. So just because we're over the peak and things are starting to plateau and indeed come down, there are still staff working across the healthcare sector well above what they would normally do. So as we try to I can't go to the next slide. So as we try to start reintroducing services, it's important to ensure that critical care has the capacity to support this, not just in physical space, but drugs and consumables and adequate staffing levels that are sustainable for the medium to long term. I think it's going to be very difficult to get back to where we were pre-pandemic, and that may not be the right place to go. But we need to make sure that there's a balance between the return to the pre-pandemic standards and restoring normal activity, whilst at the same time maintaining patient safety and, most importantly, staff health and well-being. As critical care is required for much of the acute hospital to function, we need to ensure it remains resilient to support both COVID and non-COVID activity over a sustained period of time. At the beginning of the pandemic, the UK had around 3,600 adult critical care beds, but not all of these beds were available, partly due to staffing shortages. And in order to meet the demands from COVID, we've had to dramatically change the model of critical care delivery by redeploying non-critical care staff. Everyone's worked tirelessly in unfamiliar environments and in exceptional circumstances in order to care for COVID and non-COVID patients. So although the number of COVID admissions to critical care is falling, there are a significant number of patients whose length of stay is prolonged, and they will still be in intensive care for a long period of time to come. We also remain above baseline occupancy rates of 85%. And that makes the faculty and everyone working in critical care concerned, because as non-critical care staff are redeployed back to their normal areas of work, the expanded critical care force will be depleted. And we're going to need to deliver critical care probably in a number of different sites so that we can separate COVID and non-COVID patients. And that means, although we may be back down to baseline capacity, and we may be back down to normal levels of staffing, we'll lose the economies of scale, and therefore we may not be able to deliver even the baseline capacity. And that needs to be taken into account when we restore critical care, well, acute hospital activity. So I think our surge plans have worked well. A lot of the changes have been done in an ad hoc way, mainly due to the extent of the expansion required. But what we really need to do is to maintain our emergency reserve workforce. We can't lose the skills that the non-critical care staff have acquired. And one of the things the faculty is looking at is how we do this. One simple way may be to change some of the mandatory training that we have to do on an often annual basis, and we can't often see the point of it. And maybe we need to relook at that and make sure that some of the skills that have been acquired can be maintained for future surges or future pandemics. We obviously have issues with staffing, but we can't create highly skilled staff overnight. So maybe what we need to do is to look at new models of care. Enhanced care, which is a level of care between the ward and between critical care, would offer a solution, particularly for patients on a perioperative pathway. It would support the restoration of surgical services. Enhanced care would mean patients were looked after safely, and it would also mean that we wouldn't be dependent on critical care staff for delivery, because non-critical care staff, particularly anaesthetists and surgeons, have the skills and competence required to manage the perioperative patient. So this would take the pressure off critical care. The Faculty of Intensive Care Medicine, along with the 3 Royal Colleges of Physicians, have a guidance document that we were due to publish on the 28th of March, but put it on hold because of the pandemic. And we are just looking at it to make sure that it is COVID relevant. And we'll
Alison,
be publishing
I'm going to have to ask you to draw to a conclusion, because we're going to fall off the end. Thank you so much.
We will be launching that in the next few weeks. And finally, we need to consider the patients who will need considerable degrees of rehabilitation and follow-up. And again, we'll be launching some guidance on that in the next 48 hours. Thank you.